Welcome to the Hospital Medicine Unplugged podcast. Our mission today is highly focused, conducting a comprehensive deep dive into the latest evidence, nuanced controversies, and practical implementation of the Surviving Sepsis Campaign, or SSC 2021 guidelines for the management of septic shock.
Right.
We are specifically integrating the critical data derived from recent high-impact publications, notably those from the NEJM and JAMA.
And this focus is absolutely essential. As hospitalists, as physicians on the front line, we're managing patients with crude hospital mortality rates still hovering around, 40%, sometimes higher.
It's staggering.
It really is. And the difference between aggressive, evidence-based management and maybe less targeted care often hinges on pretty subtle clinical decisions, especially in that first crucial hour and then, the subsequent 24 hours of resuscitation.
Delays are just unforgiving in this state.
Completely. There's very little room for error.
So today, we'll start with the essential sepsis 3 definition. We need to analyze precisely how that definition identifies the high-risk patient population we're dealing with.
Okay.
Then we'll move into the complex pathophysiology, explore the practical application, maybe some limitations, of screening and diagnostic tools.
Like QSOFA and SOFA.
Exactly. And then spend significant time really dissecting the Hour-1 management bundle, and crucially, analyze that paradigm shift, moving away from the older, maybe more rigid, protocolized care.
Like the original EGDT.
Right, towards the current standard of highly individualized, physiologically guided hemodynamic assessment.
Okay, sounds like a good plan. So let's start with that foundation, the sepsis 3 definition. It really established a consensus for, everything: triage, prognostication, research consistency.
And its main clinical utility, wouldn't you say, is providing that precise identifier for the highest risk subset.
Absolutely. We have to distinguish septic shock from sepsis alone. And the key is defining it by the simultaneous presence of profound circulatory failure and some element of cellular or metabolic derangement. It's both.
So operationally, how do we define that at the bedside? We're looking for a patient, confirmed or suspected infection, who has persistent hypotension needing vasopressors, right?
Yes, specifically requiring vasopressor therapy to keep that mean arterial pressure, the MAP, that's 65 millimeters of mercury or greater. That's the circulatory failure piece.
But that's not enough on its own.
No, absolutely not. It has to be coupled with that metabolic abnormality, the one that reflects ongoing tissue hypoperfusion despite our initial fluid efforts. So the patient must also have a serum lactate level of 2.0 millimoles per liter or greater.
Even after giving fluids.
Despite adequate fluid resuscitation, that's the critical qualifier. That dual requirement, vasopressor dependence and persistent hyperlactatemia after fluids, that's our clinical anchor for septic shock.
And the prognostic power of getting that definition right is just immense.
It really is. By demanding both components, sepsis 3 isolates the patients who are truly in the most danger. Clinically, we know these patients face those hospital mortality rates often exceeding 40%. It's a very specific definition for a severe state.
And it was a necessary evolution, wasn't it, compared to the older SIRS criteria?
Oh, definitely. Its development was crucial because it showed much better prognostic accuracy. The old SIRS systemic inflammatory response syndrome criteria, they were sensitive, sure, but not specific.
Caught too much noise.
Exactly. Too many inflammatory states that weren't true circulatory collapse. This newer threshold, sepsis 3, it compels immediate, aggressive, ICU-level care and resource allocation, and the evidence really backs that up.
Okay, that sets the stage perfectly, understanding who we're dealing with. Now let's unpack the why, the pathophysiology, because understanding the mechanism really drives our interventions later on. Septic shock is fundamentally rooted in a disastrously dysregulated host response.
It's an orchestrated cellular catastrophe, really. The initial trigger, you have these pathogen-associated molecular patterns, PAMPs, from the microbes, and damage-associated molecular patterns, DAMPs, from injured host cells.
Right.
These activate pattern recognition receptors on immune cells, endothelial cells, you name it. And this kicks off this massive, often uncontrolled production of cytokines, IL-1, IL-6, TNF-alpha, creating that cytokine storm we hear about.
But what's so challenging about sepsis, or maybe clinically frustrating, is that it's not just hyperinflammation. It's happening at the same time as profound immunosuppression.
That's a critical point. It's not simple immune overdrive. While you have the cytokine storm raging, the body's defenses are simultaneously being exhausted. We see things like massive lymphocyte apoptosis, impaired monocyte function, defects in innate immunity.
Which leaves the patient incredibly vulnerable.
Exactly. Vulnerable to secondary nosocomial infections, and that vulnerability can persist long after the initial septic insult is theoretically cleared.
And clinically, what we see, the vasodilation, the capillary leak, that's largely driven by endothelial injury, isn't it? That seems central.
Absolutely central. The cytokine storm directly attacks the endothelial barrier. This leads to the loss of the protective endothelial glycocalyx, that sort of gel-like layer lining the vessels.
Normally keeps things in check.
Right. It regulates vascular tone, permeability. When it's damaged or lost, you get massive vascular permeability. Fluid leaks out everywhere. That's the capillary leak, driving systemic edema, the third spacing. It also contributes to microvascular thrombosis, like we see in DIC.
And that loss of vascular integrity directly causes the relative hypovolemia we're trying to combat with fluids.
Yes. And the resulting circulatory collapse is sort of threefold. First, profound systemic vasodilation, driven largely by excessive nitric oxide and prostaglandins. Second, the actual volume loss, the hypovolemia from that capillary leak. And third, a direct hit on the heart inflammatory mediators cause myocardial depression, often presenting as a kind of reversible cardiomyopathy.
So tying this back to the sepsis 3 definition, that elevated lactate, it's not just about poor blood flow in the big vessels, is it?
No, it's often more complicated than that. It's frequently fueled by mitochondrial damage and dysfunction within the cells themselves. Oxidative stress impairs the cell's ability to use oxygen efficiently, even if we're delivering plenty of it.
Sometimes called cytopathic hypoxia.
Precisely. This failure of cellular oxygen utilization directly contributes to the metabolic acidosis and the hyperlactatemia, even if, global oxygen delivery seems adequate based on our usual measures. The cell's engine is sputtering.
Okay, that complex picture helps understand the targets. Now, shifting gears slightly to etiology, knowing the common sources and pathogens is just critical for getting those initial empiric antibiotics right and quickly. In a typical hospitalized patient, where do most septic shock cases originate?
They tend to cluster pretty predictably. Pulmonary infections, mostly pneumonia, they're the biggest group overall, responsible for maybe 40 to 60% of cases. Then you have intra-abdominal infections, think complicated appendicitis, diverticulitis, cholangitis, things like that. That's typically the next chunk, maybe 15 to 30%.
And rounding out the top 3.
Genitourinary infections, often ascending pyelonephritis or, importantly, infections related to urinary obstruction. They also fall in that kind of 15 to 30% range. If you cover those 3 areas, lungs, abdomen, GU tract, you've covered the vast majority of likely sources.
And the bugs themselves. We need our empiric regimen to cover the usual suspects, but also factor in local resistance patterns.
Yeah, the distribution varies regionally, of course, but consistently in ICU settings, gram-negative bacteria tend to dominate, sometimes causing up to, say, 62% of isolates.
But we can't forget gram-positives.
Absolutely not. We have to remain vigilant for things like staph KO casi and strep KO casi. They're extremely common and can cause incredibly rapid fulminant shock. And increasingly, fungi, especially Candida species, are important players, particularly in patients who've been in the hospital a long time or are immunosuppressed.
So for us as hospitalists, identifying those specific risk factors for multi-drug resistant organisms, or MDRs, and fungi is probably the most crucial step before clicking order on the antibiotics. What flags should immediately make us broaden our coverage?
Key high-risk indicators would be things like prolonged critical illness itself, recent hospitalization, prior exposure to broad-spectrum antibiotics, say within the last 90 days.
Right.
Indwelling lines, central venous catheters, urinary catheters, mechanical ventilation is another big one. And then any state of significant immunosuppression, think neutropenia from malignancy, post-transplant status, even poorly controlled diabetes.
So if those are present, our default empiric regimen needs to be wider.
Yes, significantly broader, maybe considering double coverage for Pseudomonas or other resistant gram-negatives, and potentially empiric antifungal therapy, depending on the overall picture.
And critically, the source itself carries prognostic weight, right? Yeah. It informs how aggressively we need to pursue source control.
Absolutely. Some sources are just inherently more dangerous. For instance, a straightforward UTI associated with an obstructing kidney stone, while serious, often has a lower mortality if you can relieve the obstruction quickly with a stent or nephrostomy tube. The source is contained and drainable.
Makes sense.
But contrast that with, say, ischemic bowel or necrotizing pancreatitis or a severe intra-abdominal catastrophe. Those are associated with the highest mortality rates. In those cases, the speed of source control, often meaning emergent surgery, becomes a major determinant of survival.
That urgency really brings us nicely to the next phase, diagnosis and screening. And this has to happen basically simultaneously with starting stabilization efforts. For that rapid bedside triage, especially outside the ICU, we often rely on the quick SOFA or QSOFA score.
Right, and the purpose of QSOFA is purely rapid screening. It's designed to quickly flag patients with suspected infection who might be at high risk for poor outcomes. We all know the criteria: respiratory rate 22 or more.
Systolic blood pressure 100 or less.
And any altered mentation. Get 2 out of those 3, and it should trigger an immediate sepsis alert and prompt further investigation and likely escalation of care.
But the key limitation for our audience, for physicians, is understanding that QSOFA isn't very sensitive.
That's crucial. It has lower sensitivity than the full SOFA score, so it will miss a significant chunk of septic patients, especially those who are maybe still normotensive or just subtly confused early on. Its value is as a trigger for escalation in a non-ICU setting. It's definitely not a reliable rule-out tool.
So if a patient gets escalated to the ICU, or if they're already there, then the full sequential organ failure assessment of the SOFA score that becomes the preferred tool.
Yes, that's our standard for quantifying the extent of acute organ dysfunction in the ICU. We use it to track the patient's trajectory, assess severity over time.
And the clinical threshold there is pretty clear. An increase in the SOFA score of 2 points or more from whatever their baseline was. That signifies acute organ dysfunction and, importantly, a markedly increased mortality risk. It gives us a number, essentially reflecting how sick the patient is across multiple organ systems.
Okay, so screening and assessment tools. Then laboratory essentials. Obviously, serum lactate is front and center. We've already established its role in the diagnostic definition, that cutoff of 2.0 millimoles per liter after the initial fluid bolus.
Right, but its role extends beyond just diagnosis, doesn't it? It's a vital monitoring tool.
Absolutely vital. Lactate is our key biochemical marker of tissue hypoperfusion, and it correlates directly with severity and prognosis. The SSC 2021 guidelines really hammer this home. Resuscitation should be guided in part by decreasing elevated lactate levels.
We're looking for lactate clearance.
Exactly. A drop of, say, 10 to 20% every couple of hours is a good target. It's a concrete measure suggesting our resuscitation efforts are actually improving tissue oxygen delivery or utilization. If that lactate stays stubbornly high, or even worse, starts rising despite hitting our MAP target,
That's a bad sign.
it's a very bad sign. It suggests ongoing hypoperfusion, maybe microcirculatory failure, maybe that mitochondrial dysfunction we talked about. It forces you to reevaluate your entire strategy. Are they fluid responsive? Do they need more pressor? Is there an uncontrolled source?
And of course, the microbiology workup. Critical, but with a time pressure.
Yes. Blood cultures, ideally 2 sets from different sites, plus urine cultures, sputum if appropriate, any other site-specific cultures based on suspected source. These must be obtained before starting antibiotics, ideally.
But the clock is ticking.
The clock is absolutely ticking. We cannot sacrifice timely antibiotic administration for culture acquisition. If getting those cultures is going to delay antibiotics beyond that critical hour-1 window, especially in a patient clearly in shock,
You give the antibiotics first.
you give the antibiotics. The risk of increased mortality from delayed treatment far outweighs the marginal benefit of getting pristine pretreatment cultures in that specific urgent scenario. Treatment is the priority.
Okay, which brings us squarely into management. This is where, as you said, the evidence has really shifted over the last couple of decades, but the core principle is still urgency. That hour-1 resuscitation bundle demands immediate action.
Immediate action. Starting with fluid resuscitation. The initial SSE recommendation remains giving at least 30 milliliters per kilogram of intravenous crystalloid fluid within the first 3 hours for patients with hypotension or signs of hypoperfusion.
But even that comes with caveats now.
It does.
Yeah.
Even that initial bolus recommendation is graded as a weak recommendation based on low-quality evidence in the 2021 guidelines.
Downgrade.
It reflects the uncertainty and the significant heterogeneity in how septic shock presents. Not everyone needs or benefits from a rigid 30 milliliters per kilogram up front. Some might need less, some might need more, and some might be harmed by it if they have underlying heart failure, for example.
And the type of crystalloid matters more than we used to think. The balanced versus saline debate seems largely settled.
It does seem largely settled for most patients. The evidence now clearly favors balanced crystalloids, things like lactated ringers or plasmolite, over standard 0.9% saline.
Because of kidney injury.
Primarily, yes. We have good data now from trials like SMART and SALT-ED showing that large volumes of 0.9% saline are associated with hyperchloremic metabolic acidosis and potentially increased rates of acute kidney injury compared to balanced solutions.
Saline just isn't physiologic.
It really isn't. That huge chloride load way above plasma levels seems to cause afferent renal vasoconstriction and can contribute to kidney damage. So for the vast majority of septic shock patients, a balanced crystalloid should probably be your default choice. You reserve saline for specific situations like maybe severe hypochloremia or perhaps traumatic brain injury where you want that hypertonicity.
But the biggest shift, the real transformation in fluid management, has been moving away from those rigid, protocol-driven approaches. We have to talk about the initial early goal-directed therapy, EGDT, from Rivers back in 2001 in the NEJM. That really set the stage for a decade or more of practice.
It absolutely did. That trial ushered in an era of very aggressive resuscitation, heavily reliant on targeting central venous pressure, CVP, and central venous oxygen saturation, SCVO2, often leading to very large fluid volumes being administered early.
It was widely adopted, almost dogma for a while.
It was. But then came the big three multi-center trials, Process in the US, Arise in Australasia, and Promise in the UK. These were huge trials randomizing thousands of patients to either that strict, protocolized EGDT or to what was essentially usual contemporary standard care.
And the results were consistent across all three.
Remarkably consistent. All three trials concluded that the rigid, protocolized EGDT bundle did not offer any additional survival benefit compared to standard, prompt, goal-oriented care guided by the treating physician's judgment.
So the takeaway isn't that early resuscitation is bad.
Not at all. The key insight, I think, is that the usual care arms in those trials were actually providing very good prompt care. They confirmed that the really critical elements are rapid antibiotics, an appropriate initial fluid challenge, and early initiation of vasopressors if needed, basically, the core components of the Hour-1 bundle.
It seems the extra steps in the rigid EGDT protocol, particularly the large, often CVP-guided fluid volumes and routine transfusions or inotropes based on SCVO2 alone, didn't add benefit and potentially introduced harm.
Exactly, particularly the risk of iatrogenic harm from fluid overload, which we now recognize as a major problem, worsening respiratory function and potentially increasing mortality.
Which is why the guidelines now pivot so strongly towards dynamic measures to guide ongoing fluid resuscitation after that initial bolus.
Yes. We simply cannot rely on static parameters anymore. Central venous pressure, CVP, is a notoriously poor predictor of whether a patient will actually benefit from their fluid responsiveness. Even physical exam findings alone are often insufficient.
So we need to actively assess fluid responsiveness.
We must. We need measures that predict how the patient's hemodynamics, specifically their cardiac output or stroke volume, will change in response to a fluid bolus before we give it.
And the standard of care now involves things like the passive leg raise maneuver.
That's a key one. It acts like a reversible internal fluid challenge. You raise the legs, watch for a temporary boost in stroke volume or cardiac output using minimally invasive monitoring or even POCUS ultrasound. If they respond, they might benefit from actual fluid. If not, giving more fluid is likely futile and potentially harmful.
Other dynamic measures.
In intubated patients on controlled ventilation, you can use stroke volume variation, SVV, or pulse pressure variation, PPV, from an arterial line. Bedside ultrasound, or POCUS, is also incredibly valuable looking at IVC diameter and collapsibility or directly assessing cardiac function and changes with maneuvers like the leg raise. This individualized dynamic approach is designed specifically to maximize benefit while minimizing the significant danger of fluid overload.
Okay, so fluids are dynamically guided. What if hypotension persists despite that initial appropriate fluid challenge? That's when vasopressors come in.
Immediately. Sometimes even concurrently with the initial fluid bolus if the patient is profoundly hypotensive, like MAP below 50. You don't wait. And the guidelines are unequivocal. Norepinephrine is the preferred first-line vasopressor.
Why norepinephrine specifically?
It offers a good balance. It has potent alpha-adrenergic effects, which increases systemic vascular resistance, raises blood pressure by vasoconstriction, but it also has sufficient beta-1 adrenergic activity to provide some modest increase in cardiac output and contractility, usually without causing excessive tachycardia, unlike pure alpha agonists or high-dose dopamine.
And the target MAP, still 65.
The initial target MAP generally remains 65 millimeters of mercury. There was a large trial, Sepsis-PAM, that compared targeting an MAP of 65-70 versus a higher target of 80-85. It found no overall mortality benefit with the higher target in the general septic shock population. In fact, the higher target group had a significantly higher rate of arrhythmias, like atrial fibrillation.
But maybe some nuance there. Patients with chronic hypertension.
That's the main caveat. In patients with known severe chronic hypertension, their autoregulation curves might be shifted. So a MAP of 65 might represent relative hypotension for their brain or kidneys. In those specific patients, cautiously targeting a slightly higher MAP, maybe 70 or 75, might be reasonable, but it needs careful consideration and monitoring for adverse effects. It's not a routine strategy.
Okay, so norepinephrine first, target MAP 65 generally. What if we're escalating the norepinephrine dose and still not reaching our target MAP? What are the next steps, the adjunctive agents?
The guidelines typically suggest adding either vasopressin or epinephrine as the second agent. Vasopressin is very commonly added second.
Why vasopressin?
It acts on V1 receptors in vascular smooth muscle, causing vasoconstriction through a completely different pathway than catecholamines. This means it can work even when adrenergic receptors might be downregulated or saturated. It also seems to have a catecholamine-sparing effect, potentially allowing you to reduce the norepinephrine dose. It's usually added at a fixed low dose, like 0.03 units per minute.
And the alternative is epinephrine.
Epinephrine is the other main option. It provides much stronger beta-1 stimulation than norepinephrine, so it gives a significant boost in heart rate and contractility, inotrop, along with potent vasoconstriction, alpha effects.
So the choice depends on the specific hemodynamics.
Often, yes. If the primary problem seems to be profound vasodilation, vasoplegia, with relatively preserved cardiac function, vasopressin might be the more logical add-on. If there's evidence of significant myocardial depression contributing to the shock state, epinephrine might be preferred for its stronger inotropic support. Sometimes you end up needing all three in refractory shock.
Now, a practical point that's gained a lot of traction. Peripheral administration of vasopressors. Is it safe? Is it recommended?
It's increasingly recognized as safe and is often necessary to facilitate early initiation. The key is using a large bore wavy, ideally 18 or 20 gauge, placed in a large vein, preferably proximal like in the antecubital fossa or higher, not in the hand or wrist.
Why the shift? It used to be central line only.
Because delaying initiation of vasopressors while waiting for central line placement can be detrimental. That Hour-1 bundle completion is critical. Starting pressors peripherally allows you to stabilize the patient hemodynamically while you arrange for central access, which is still generally preferred for longer-term or high-dose infusions.
But you need to be vigilant.
Extremely vigilant. Frequent site checks are mandatory to watch for any signs of extravasation pain, swelling, blanching. If extravasation occurs, you need to stop the infusion immediately and potentially administer an antidote like phentolamine locally. But overall, the benefits of starting pressors early often outweigh the risks of temporary peripheral administration, provided it's done carefully.
Okay, fluids and pressors covered. Now, arguably the most time-sensitive intervention. Antimicrobial therapy.
Timing is, without exaggeration, life here. Early administration of appropriate broad-spectrum antimicrobials, ideally within that first hour of recognizing septic shock, is probably the single most critical determinant of survival.
The data on delays is pretty stark.
It is. Multiple observational studies have shown a clear, almost linear relationship. For every hour delay in getting effective antibiotics into a patient with septic shock, mortality increases significantly.
So selection has to be rapid, but also thoughtful.
Absolutely. The empiric regimen must be tailored. You have to consider the suspected source of infection. Critically, the local hospital and community antibiogram, knowing your local resistance patterns, is non-negotiable.
Right.
And as we discussed, the individual patient's risk factors for MDR organisms or fungi. You need broad coverage initially, hitting the most likely pathogens based on that assessment.
And then de-escalation is key later on.
Crucial. Once the patient is stabilizing and you get culture results back, usually within 48 to 72 hours, you must make a concerted effort to de-escalate or narrow the antibiotic spectrum. Target the identified pathogens, stop redundant coverage. This minimizes toxicity, reduces the risk of C. difficile, and helps combat antimicrobial resistance.
And antibiotics alone aren't enough if there's a source that needs physical removal or drainage. source control.
Source control is the other absolutely essential pillar, alongside antibiotics. If there's a collection of pus, like an abscess, that needs drainage, or an infected piece of hardware, like a central line or prosthetic joint that needs removal, or dead tissue, like a necrotizing fasciitis,
It has to be dealt with.
it has to be dealt with, and as soon as possible. You can pour antibiotics into the patient, but if there's an ongoing nidus of infection that isn't physically addressed, the infection will persist, the patient likely won't recover. For things like perforated bowel or necrotizing soft tissue infection, this often means emergent surgery is required alongside the antibiotics and resuscitation.
Okay, that covers the core Hour-1 and immediate stabilization. Let's move into adjunctive therapies and ongoing monitoring. This area often has more debate. Corticosteroids are always a hot topic.
They remain probably the most commonly discussed and perhaps debated adjunctive therapy. The current thinking, reflected in the SSC guidelines, is that low-dose corticosteroids, typically hydrocortisone 200 milligrams per day, given either as a continuous infusion or in divided doses, may be considered.
But only in specific patients.
Yes, specifically in patients with refractory septic shock. That means patients who remain hemodynamically unstable, needing ongoing or escalating vasopressor support, despite seemingly adequate fluid resuscitation and reasonable doses of first and potentially second-line vasopressors.
And the recommendation is weak, isn't it?
It is a weak recommendation, and the evidence quality is considered moderate. This reflects the conflicting results from major trials. The adrenal trial, which was very large, showed no significant difference in 90-day mortality, although shock resolved faster in the steroid group. The APRO-CHSS trial, which combined hydrocortisone with fludrocortisone, did show a mortality benefit, but had some methodological differences.
So the impact on actual survival is still unclear.
It's less clear than we'd like. The most consistent finding seems to be that corticosteroids hasten shock reversal. They help patients get off vasopressors faster. Whether that translates into consistently saving more lives is still debated.
And there are definite downsides.
Oh yes, we have to remember the risks. Even these low or stress doses of hydrocortisone reliably cause hyperglycemia, which necessitates more intensive glucose monitoring and often insulin therapy. There's also a theoretical, though not always definitively proven in trials, increased risk of secondary infections or perhaps muscle weakness with prolonged use.
So the current practice is pretty individualized.
Very much so. Many clinicians will use them in refractory shock primarily to accelerate hemodynamic stability and wean vasopressors sooner, especially if doses are very high. But they shouldn't be seen as a magic bullet or used routinely outside of that refractory setting, unless, of course, the patient has known or suspected adrenal insufficiency.
And what about other adjunctive therapies that generated buzz but maybe haven't panned out? Vitamin C comes to mind.
Right. The high-dose intravenous vitamin C protocols, often combined with thiamine and hydrocortisone, sometimes called the Merrick cocktail, generated a lot of initial excitement based on observational data.
But randomized trials were less positive.
Exactly. Subsequent larger randomized controlled trials like the vitamins trial, ACTS, Lovett, Atrasali, unfortunately failed to consistently demonstrate significant improvements in survival or other major outcomes compared to placebo or standard care. So, based on current high-quality evidence, routine use of high-dose vitamin C is not recommended by the SSC guidelines.
What about beta blockers? There was some thought about using them to control the tachycardia in hyperdynamic sepsis.
Yes, the idea was that excessive tachycardia could be maladaptive, increasing myocardial oxygen demand. Using short-acting beta blockers like esmolol was explored to try and temper that heart rate response. However, again, randomized trials haven't shown consistent benefit, and there's concern about potentially worsening hypotension or cardiac output in some patients. So it's also not routinely recommended currently.
Are there any newer agents on the horizon or in use for very refractory cases?
Well, one agent that has gained FDA approval, although not yet a standard first or second-line therapy in SSC guidelines, is angiotensin II. It's a potent vasoconstrictor that acts directly on AT1 receptors.
A different mechanism again.
A different mechanism, yes. It's typically reserved for patients with refractory vasodilatory shock who remain hypotensive despite high doses of norepinephrine, vasopressin, and potentially epinephrine. The ATHOS-3 trial showed it was effective at raising MAP in this very sick population. It reinforces that idea that in truly refractory shock, we might need to think about attacking the vasodilation from multiple pharmacologic angles.
Okay, so adjunctive therapies are nuanced. Let's talk about ongoing monitoring once the patient is stabilized but still critically ill. The focus shifts from just the Hour-1 interventions to sustained, vigilant assessment.
Absolutely. The foundation of that individualized care we talked about is continuous reassessment and titration based on the patient's physiologic response. We can't just set the drips and walk away.
And the focus remains squarely on perfusion.
Dynamically assessing perfusion is critical. We continue serial assessment of lactate clearance. Are those levels continuing to trend down? That remains important. But increasingly, the guidelines and recent evidence are highlighting the value of clinical perfusion markers as well.
Like capillary refill time.
Exactly. Capillary refill time, or CRT. It's simple, non-invasive, can be done quickly at the bedside. You press on the fingertip or kneecap, see how long it takes for color to return. A prolonged CRT, typically more than 3 seconds, suggests poor peripheral perfusion.
And there's trial data supporting its use.
Yes, the Andromeda Shock trial compared a resuscitation strategy guided by normalizing CRT versus one guided by normalizing lactate levels. It found that the CRT-guided strategy was associated with trends towards lower mortality and faster resolution of organ dysfunction, although the primary outcome difference wasn't statistically significant. It suggests CRT is, at minimum, a very useful adjunct, and perhaps even a primary target in some settings, especially where lactate measurement might be delayed or unavailable.
Makes sense. What else are we continuously monitoring?
We need continuous assessment of end organ function beyond just perfusion markers. That means meticulous tracking of hourly urine output. Is the kidney being perfused adequately? Rigorous monitoring for altered mental status and delirium, often using standardized tools like the CAM-ICU. Delirium is incredibly common and associated with worse outcomes.
And keeping an eye on vital signs beyond just MAP.
Yes. Managing the overall pattern, trying to minimize persistent tachycardia and tachypnea, while sometimes necessary compensations, if they persist despite resolving hypotension, it might indicate ongoing stress, pain, anxiety, or inadequate resuscitation that needs addressing.
And throughout this phase, safety and harm mitigation are paramount. We're watching for the downsides of our own interventions.
Constantly. We need vigilance for iatrogenic harm. That means looking for clinical signs of volume overload worsening oxygenation, pulmonary edema on imaging, rising CVP if measured, which is a direct consequence of over-resuscitation.
And adverse drug effects.
Yes. Monitoring for things like hyperglycemia from corticosteroids, arrhythmias from vasopressors, potential nephrotoxicity from antibiotics like vancomycin or aminoglycosides, and, as mentioned, local tissue injury from peripheral vasopressor extravasation. It's a balancing act.
Okay, finally, let's address the grim realities. Complications and prognosis. Even with optimal care, septic shock takes a heavy toll. The initial insult often triggers a cascade of acute organ failures.
It really does. The dysregulated immune response and hypoperfusion guarantee a high incidence of organ dysfunction beyond just the circulatory system. Acute respiratory distress syndrome, ARDS, is a major complication, frequently requiring mechanical ventilation with lung protective strategies.
Kidneys take a big hit, too.
Acute kidney injury, AKI, is extremely common, often severe enough to require renal replacement therapy, like dialysis. Myocardial depression, as we discussed, can persist and contribute to ongoing shock, and disseminated intravascular coagulation, DIC, that consumptive coagulopathy, can lead to both bleeding and thrombosis, complicating everything.
And our interventions themselves carry risks, even beyond fluid overload.
Right. We have to be attuned to those iatrogenic risks. High-dose vasopressors can cause tachyarrhythmias or peripheral visceral ischemia. Indwelling lines, while necessary, are always a potential source for secondary infections, particularly catheter-related bloodstream infections. And data suggests femoral central lines carry a higher infection risk than subclavian or internal jugular sites, influencing our placement choices.
So, despite all our efforts, the prognosis remains serious. What are the mortality figures generally cited?
Even in the modern era, with all these advances, crude hospital mortality rates for septic shock remain distressingly high, generally fluctuating somewhere between 30% and 40%. It's still one of the leading causes of death in intensive care units worldwide.
And for the patients who do survive the initial ICU stay, it's often not a simple return to normal life.
Far from it. Survivors face a very guarded prognosis and often suffer from a constellation of long-term problems collectively known as post-intensive care syndrome, or PICS.
What does that encompass?
It's broad. Critical illness, polyneuropathy, and myopathy, nerve and muscle damage from prolonged inflammation and immobility are extremely common. These lead to profound weakness, difficulty with walking, needing prolonged rehabilitation, and often causing long-term functional impairment, impacting their ability to work or perform daily activities.
And it's not just physical.
No, the cognitive and emotional toll is huge. Survivors frequently experience persistent cognitive deficits. Problems with memory, attention, executive function, and mental health issues are rampant. High rates of anxiety, depression, and post-traumatic stress disorder related to their frightening ICU experience.
That long-term burden is really why the latest guidelines emphasize outcomes beyond just hospital survival.
Exactly. The SSC 2021 guidelines specifically mention the importance of considering long-term outcomes. They include recommendations for things like assessing rehabilitation needs, screening for common PICS symptoms, ensuring patients have adequate social support upon discharge, and facilitating appropriate follow-up care. It's a crucial shift, acknowledging that our responsibility doesn't end when the patient leaves the ICU or even the hospital.
Okay, let's try to summarize this comprehensive deep dive. If there's one core lesson from the SSC 2021 guidelines, informed by those landmark trials like Process, Arise, and Promise, what is it?
I think the fundamental paradigm shift is this. While the urgency of that Hour-1 bundle, rapid fluids, pressors if needed, and especially antibiotics, is absolutely non-negotiable.
That hasn't changed.
That hasn't changed. But we have decisively moved away from a rigid, one-size-fits-all, protocolized approach based on fixed static targets like CVP, or even just SCVO2 alone.
Toward what?
Towards continuous, highly individualized, physiologically guided resuscitation. We must use dynamic measures like the passive leg raise, like POCUS assessment of cardiac function and fluid tolerance, and serial perfusion markers like lactate clearance and clinical signs like capillary refill time to guide every subsequent decision about fluids and vasopressors. The goal is constant titration to the patient's real-time needs, maximizing benefit while actively trying to minimize iatrogenic harm, especially from fluid overload.
A much more nuanced, tailored approach.
Definitely. More thoughtful, less reflexive.
And that leads perfectly into our final provocative thought for you, our listeners, fellow clinicians. Navigating this incredibly challenging syndrome, we acknowledge the complexity, the high mortality of the initial septic insult. But for the 60 to 70% of patients who do survive that acute phase, their journey is often just beginning, defined by prolonged recovery and that significant burden of persistent morbidity we just discussed.
Right. So the challenge for us now, as a healthcare system and as individual practitioners, is really evolving our focus beyond just acute survival. The provocative question, I think, is this. How do we, as hospitalists, as critical care teams, as primary care physicians receiving these patients post-discharge, how do we better integrate early rehabilitation interventions, physical, cognitive, emotional, perhaps starting even during the critical care phase?
And combine that with robust screening for PICS, extending support well into the outpatient setting?
Exactly. How do we systematically build pathways to effectively mitigate the lasting physical, cognitive, and emotional damage in those who recover? We're now challenged, I think, to focus just as intently on the quality of the life saved as we do on the initial act of saving it.
A profound challenge indeed, and one that requires collaboration across the entire care continuum. Thank you for joining us on this deep dive into septic shock management.